everybody, and welcome back. This is our second video for our elective, and this one is just an overview of some selected atrial dysrhythmias. There are certainly more than we are going to cover, but I think that these are the ones that are the most common, the ones that you are going to see the most often, and the ones that we want to focus on for the purposes of this course. So let's start with a little bit of a definition. So you're going to hear people talk about patients having ectopy or ectopic beats, and that language could be used about atrial ectopy or ventricular ectopy. But let's just talk about what the heck that means. That just means that there has been electrical activity that started an electrical conduction that was not the SA node. It didn't start where it was supposed to. It is outside of that barrier. It's ectopic. Ectopic beats can come from one place, unifocal, or can come from multiple places, multifocal. Like we'll see this with AFib. AFib is a real multifocal sort of issue. The ones that we are going to focus on in this presentation are premature atrial contractions, PACs, atrial flutter, which is similar to atrial fibrillation, but we'll look at the difference. We are not going to talk about Wolff-Parkinson-White, WPW, or wandering atrial pacemaker today. If you are desperate to look at those for your own personal enrichment, you are welcome to do that. And there are certainly other atrial rhythms as well. But I want to focus on these three. Let's talk about PACs first. PACs are super common. They can happen for a lot of different reasons, and they don't necessarily mean that anything is wrong with the heart. All a PAC is an early contraction. It happened, or it's not regular. It didn't happen when it was supposed to. For some reason, that SA node fired off, or something near the SA node fired off before it was supposed to. It got into the normal conduction pathway, went down through the AV node. I'm looking for my picture. So it fired from somewhere around here, got down through the AV node, went ahead and went through the Purkinje fibers, innervated the ventricles, but it was rogue. It happened too early. It didn't wait for the time that it was supposed to wait. So on this particular strip, you can see, like this is a computer generated one, but you can see that this looks pretty regular, right? Like these look normal. But if I would start to measure out, so let's compare the regularity of these as, well, that didn't work there. That one was early there. That one was early there. So I can see that that R to R is irregular. And if I were to march out the P waves, let me try to find some P's that look like P's over here and march them out. Like that one comes right up. That one's a little bit early. Let's go back here. That one's off. So you can see that that isn't regular either, because I've got some premature firing up here in the PACs. But I still know it came from the atria. The signal that originated this beat came from the atria because this QRS is skinny. A QRS that's less than 0.12 or 3 boxes is going to have happened above the ventricles, supraventricular. A QRS always tells you where it came from. So the analogy I always like to use is like accents in the United States. So people that are from the north, like me, I've lived in Illinois. I'm originally from Pennsylvania. I live further north. I don't live in the south. We tend to talk fast. We walk fast. We do everything fast. Whereas people in the south especially the deep south, they talk slow and their words are wide. And so when we get to rhythms that originate in the south of the heart in the ventricles, they're going to be slow and wide, like a southern accent. Don't be offended if you have a southern accent, but that's going to be my analogy when we get there. So PACs by themselves are not necessarily a big deal. If you start getting a bunch of these in a row, like 3 or 4 of these in a row, now we're probably going to call it atrial tachycardia. That's different from sinus tachycardia because the sinus node, the sinoatrial node, is not necessarily in charge here. But unless they start to just really string together, I'm not terribly concerned about this. And you might be thinking, why am I concerned at all about this? Well, the heart is designed to coordinate with itself. So when the atria depolarize, they are supposed to give a little bit of a pumping action to the blood that's in the upper chambers to push it down into the lower chambers to get those lower chambers nice and full of blood. And when they contract, they're filled and they eject 65% of the blood that's in there. And that's what gives your brain and your body enough cardiac output, enough volume of blood from every stroke of the heart to be able to do its business. It's getting enough oxygen, it's getting everything that it needs. Well, when you start to mess with that coordination, you get incomplete filling in the ventricles. And so incomplete filling of the ventricles means that there is less blood to be ejected out. So even if the ejection fraction of the ventricles stays pretty high, you don't have as much volume to eject out, which means less oxygen to the brain, less oxygen to the rest of the body. It can also mean a drop in blood pressure. We're going to be talking about these principles all the way through the semester. The other thing that happens with irregular heartbeats, and we're going to talk more about this with flutter and fib, is that when the ventricles cannot fully eject the way that they're supposed to, and I get that they don't eject 100% of their blood, but they slosh it around pretty good and they manage to get most of it out. When you've got incomplete filling and uncoordinated activity, blood tends to sit around in the ventricles, and blood that sits around clots, and that's a problem. Because then if you suddenly get a real good beat, you might be pumping out clots. So we'll talk more about that in just a second. So what I just mentioned a minute ago was this idea of atrial tachycardia. Don't go crazy with this. All it is 3 or more consecutive atrial premature beats, and sometimes we will call those runs. Like they had a 3-beat run of PACs or a 4-beat run. You will also hear that language about premature ventricular contractions. The thing with this is it's usually paroxysmal, and what that means is it comes and goes and you don't know when it's going to happen. So it's really hard to reproduce, or like a patient will come in and say that they felt some fluttering in their chest, like palpitations, and they felt dizzy and they didn't feel great, and they go to the doctor and they're just fine. Well, because we can't make this happen. There's a lot of reasons why it happens, but these are kind of some big ones. I'm going to guess that some of you have experienced this sort of fluttering in your chest and you thought you were going crazy. No, it was probably from this and this because, heck, you're in nursing school. Supraventricular tachycardia is a little more general. When we talk about supraventricular tachycardia, SVT, we're really only talking about narrow because it's above the ventricle. It's really fast and it's super regular. Notice that that's very different from the atrial tachycardia, that was irregular, because it's just a bunch of premature beats thrown in there. In a supraventricular tachycardia, you've usually got something other than the SA node firing really fast, but really regularly. And so you get this really, do you see, you can't even really see whether that's a P or a T or what that is. So they're probably all morphed into here together. So that's because they can be after, but they're usually just buried. You can't see the P waves in there if they're there at all, but the rate is regular and super fast. You'll hear people talking about SVT a lot. So again, primary difference between these, they both happen above the ventricle. SVT regular, atrial tachycardia irregular in its rhythm. Now let's talk about AFib. And you guys are going to be doing a whole project on AFib, because you are going to see, if you work with adults at all, a ton of patients with AFib. And AFib is multifactorial. It causes a lot of different problems. It can happen for different reasons, but it's something you need to know. So in AFib, I'm going to bring back my stellar drawing. Now, people, I know that you're jealous of my artistic skills. This is a heart. You just have to believe me. So we talked about that normally the SA node would fire, send the signal down to the AV node, and then it goes out to the ventricles. In AFib, you get multiple hot spots in the atria that are all trying to be the pacemaker of the heart. All of them are trying to be the pacemaker of the heart. They're uncoordinated. It's chaos going on up there. And usually as they all try to take over, some of these signals that they're firing, not all of them, but some of these signals they're firing are going to manage to get through to the main road and get conducted through the AV junction and out to the ventricles. But because they aren't talking to each other, the ventricles are getting signals at all kinds of different times. So what you're going to get is a very irregular rhythm. The other thing that tends to happen is that the SA node just kind of decides it's not needed anymore and it takes a vacation. So you rarely see any true P waves that look like a normal SA node firing on the strip. What you see is chaos. So you see all of these squiggles. All of this squiggliness is from the chaotic firing going on in the atria that's getting traced out here. But notice none of these are anything that you would truly call a P wave. Okay, maybe a couple. Like maybe this one, maybe this one, but they're certainly not consistent and they're happening all over the place. So if I'm looking at a rhythm like this and I just see all these squeals, I'm not even going to bother to try to measure P to P. I'm not going to try to measure PR interval because it varies so much, if I can even find it, that it's not worth it. So I would just say unable to determine or can't read it or something. The other thing I want you to notice about this is even though it looks fairly regular, it's really not in its ventricular response. So here I've got two QRSs here. Oh, that one didn't come at the same time. That one's pretty okay. That, nope, nope, nope. Do you see how they are not consistently spaced at all? That is the perfect definition of an irregular rhythm. Some people will say that AFib is regularly irregular. And all that means is that you can count on it to be irregular. It's expected to be irregular. But that doesn't mean it's not a problem. So the more spots you've got going on up here, trying to be the pacemaker of the heart, the more chances there are that beats are going to get through. And so sometimes the ventricular rate gets really, really high in AFib, and it becomes sometimes necessary to administer medications that will be negative chronotropes. In other words, they will control rate and keep it down. Because if this ventricle, I mean, it's already suffering from lack of coordination with the atria, already suffering from that, already not filling well. But if you speed up the rate even faster, that means it has even less time to fill, even less blood to eject. And so you can see significant drops in blood pressure, significant changes in mentation, because the blood, it really likes to get its oxygen. Really, really does. So that's something that we have to consider. Most of the time, this is one of those rhythms that you can kind of look at and eyeball and go, oh, yep, look at that's AFib. You see it kind of speeding up and slowing down all over the place, all of these squiggles. And so you don't necessarily have to measure this one all out to interpret it, but of course, we will practice doing those things. A similar rhythm is called atrial flutter. Atrial flutter has a lot of the same problems that AFib does, but the cause is a little bit different, and that's why the EKG looks a little bit different. And sometimes flutter can just devolve into AFib, but it's not necessary. It's not a necessary first step. So you can have AFib without ever having had flutter. You can have flutter by itself. But in flutter, what usually happens is instead of just these straight up chaotic spots, you'll wind up with a circuit that is just sending signals round and round and round and round. And every time it circles back around for one lap, it sends a P wave. Okay? But it's happening all so fast that it does not, they can't get them all through the AV junction. So typically it's pretty regular, meaning that there are 2 or 3 or 4 P waves before you see a QRS. And we typically talk about it in terms of that ratio. So if I see 1, 2, 3 P waves, 1, 2, 3 P waves, 1, 2, 3 P waves, that's a 3-to-1 flutter. But if I were to start measuring out all of these P waves, I would see that they march out equally all the way across the strip, because they are just hitting on that cycle. Every time it goes around, they're hitting on that cycle. So the P waves, notice that they're a little bit different. They have this classic sawtooth pattern, and that's something that you can often just really eyeball and see. The atria are going to get real tired of doing this. Notice that they're beating 3 times for every 1 time that the ventricles fire. You're not getting the benefit of a good atrial kick to get a lot of blood down in the ventricle. So people often feel very similar to what they do with a more rapid atrial fibrillation. They get lightheaded, they get dizzy. Both of those can be signs that the brain is not getting enough blood and therefore not enough oxygen. That's why you can get neurological changes with cardiac problems. You might see changes in blood pressure, particularly orthostatic hypotension, where they just don't tolerate positional changes as well. But notice the difference between this one and this one. So fib, irregular. Flutter, regular. Also, the atrial rate in flutter is going to be a lot higher than the ventricular rate. Same thing here, you just don't have any discernible P waves to be able to count them. So start thinking about it in terms of what they have in common and what they have that is different. Okay, so we do have a couple of practice strips on here. We can quickly walk through these. You can also see them in your PowerPoint. So this is that same flutter strip again. The AFib strip again. So assuming that this is a 6-second strip, and it's actually it's a little bit more. I think we're probably like right here for 6 seconds. I'm not concerned that this is super fast. 1, 2, 3, 4, 5, 6, 7, 8, like 80. Not too bad, but the rhythm is definitely irregular. I didn't count to see how long the strip really is. I'm sure you would get closer than me. That's abnormal. Oh, that's the ventricular rate. I can't count atrial rate. Can't count, which is also abnormal. P to R, I can't count. QRSs, though, I can look and see. And I want to, because this is how I can confirm that what I'm looking at is an atrial rhythm, a supraventricular rhythm. So I'm seeing that these QRSs are an equal width all the way across the strip. And I see that there are about 2 boxes. So I have 0.08 seconds. And I'm also, my T's are not super clear on this strip. That's hard to see. And sometimes that happens in AFib strips because the squiggle from the atria is so crazy that it's hard to find them. So sometimes I'll just look around and start to try to look for things that I think might look like T's. Like that looks like reasonably like it could be a T to me. And I'm seeing sort of an upsweep at the end of every one that are probably T's. But because I can't really see T's for sure, I'm also just going to not even try to count this. But this is obviously AFib based on its morphology. When I see a patient in this rhythm, the first thing I want to know is how long has it been going? No, that's the second thing. The second thing I want to know is how long has it been going on. The first thing I want to know is this patient tolerating this rhythm? Because you can't tell from the strip whether or not a patient's in trouble. You really can't. You have to do an assessment of them. Particularly blood pressure is going to be a priority assessment, and mental status exam is going to be a priority assessment to be able to figure out if they are tolerating this or not. If they're tolerating it okay, I've got a little bit more time to think about what to do or not do about it. So here's another strip. This one looks pretty fast. It looks fairly regular, but I'm having a hard time seeing any P waves on here. So I'm seeing a lot of T's, like these are all T's, and it's possible that there's a P in there, but I'm just mostly seeing T's, so I really can't count the atrial rate. I can count the ventricular rate just by counting all the way across, and I want to see if they're regular. And they're totally regular. I'm not going to take the time to actually count the rate right now because I don't know how close to 6 this is. But I do know that it's regular, but it's abnormal because it's fast. Can't do PR if I can't find P's, but I can do some QRS's. These look super skinny. This is not a great strip on here, so I can't quite see how many boxes. I could see it on that one. So that looks like a 0.06 seconds. QT interval. That's looking like a T to me. T, beginning of the QRS to where the T would come back to baseline. Yep, those look pretty good. And that's about 0.16 seconds. Those look pretty normal. So if this is normal, then I know it's got to be an atrial rhythm. And it's very regular, and in the absence of T waves, this is a pretty classic picture of SVT, supraventricular tachycardia. Alrighty, here's one that looks funky. So, these look like P waves to me. Also with some T waves. So I'm kind of looking at what the QRSs look like. This looks like a T wave to me right after QRSs, and then these two look kind of the same to me. So I'm seeing T, PP, QRS, T, PP, QRS, T, P, P, Q, R, S. So because of the shape of these P waves, I already know this is atrial flutter. And I can tell that it's 2 to 1. 2 P waves for every QRS. But we're still going to go through our little task here. So 1, 2, 3, 4. Let me just count ventricular first. 1, 2, 3, 4. So can you see these dark marks right here? These dark marks indicate 3 seconds. So any set of dark marks like that, if your strip has them, are 3 seconds apart. So this is 3 seconds. This is the additional 3 seconds. I know I've got a 6-second strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm going to count that as 90. And if I've got 2 Ps for every QRS, I should have 180 as the atrial rate. And I definitely want to go P to P. P to P. I'm looking for some Ps that are a little closer to the isoelectric line, but these are just not going to be, I don't think. There might even be some P's buried in those T's based on the measurement, and that could be why they look a little funky. So it really could be a 3 to 1, but I'm just going to go with what I can see. So I see that they're totally regular. They're totally regular how far they are apart. So this is regular. We went R to R. R to R is regular. So the ventricular rate is normal. It's the atrial that's abnormal. So that tells me that the problem is in the atrium. Let's find something. Let's look at the P's that are the closest to the QRSs and see if we can find a PR interval. So all these PR intervals along the isoelectric line are uniform. So they are regular, and they are about 4.5 boxes. So I'm going to say 0.18 seconds and regular. That's actually normal. Our QRSs are looking a little funky, but I think they're okay. So they're looking the same all the way across the strip, same width all the way across the strip, same morphology. And I'm seeing 0.08. It's less than 0.12, so that's normal. And a QT interval, Q to T, Q to T, Q to T, all of them. I've got one big box of 0.20 seconds, and that's normal. So based on the shapes of these P waves, based on the fact that the atrial rate is double what the ventricular rate is, I'm going with atrial flutter in a 2 to 1 ratio. So that was a very fast review of some common atrial rhythms. You are going to be doing more practice on your own. There are in the EKG Academy more practice strips you can do. I also encourage you, it has not been assigned for this module, but I do encourage you to go back to your 50 strip practice and start to pull out, based on some of these criteria that we just went through, start pulling out atrial dysrhythmias and sinus rhythms from your practice packet. See if you can practice identifying those. And as we go through, you're going to be able to identify more and more of the strips based on the skills you're learning. And it is totally okay if you don't know what they all are right now. It's also totally okay if you do, because we're still reinforcing practice. So wherever you are at, I will meet you there. So thank you again for joining me. This has been a very quick atrial dysrhythmias review and practice. And I will see you soon in discussion boards near you.